All right, today we're diving into a medical emergency where every single second is critical. Acute coronary syndrome. We're going to break down what it is, how doctors spot it, and why it's truly a race against time.
You know, we hear the term heart attack all the time, but have you ever wondered what's actually going on inside your coronary arteries when one happens? Well, that's exactly what we're about to decode, step by step.
So, at its very core, a coronary emergency boils down to a classic supply and demand problem. Just think of your heart muscle as this incredible, high-performance engine that needs a constant, rich supply of fuel. And that fuel, it's oxygenated blood. Acute coronary syndrome, or what doctors usually just call ACS, is the big umbrella term for when that fuel line, the blood flow to the heart, suddenly gets squeezed or blocked. And what happens then? You get this dangerous mismatch. The heart muscle is demanding all this oxygen, but the blocked supply just can't deliver it. That's what leads to ischemia, which is really just the medical way of saying the tissue is starving for oxygen. So you've got this crisis happening on two fronts. On one side, the oxygen supply can just plummet. A lot of the time, this is because some of that fatty plaque that builds up in an artery ruptures and a blood clot forms right on top of it, creating a blockage. Meanwhile, on the other side, the heart's demand for oxygen might be spiking, maybe from physical stress or even intense emotion. When that blocked supply can't meet the soaring demand, well, the heart muscle is starved and it actually starts to die. That process is called necrosis. Okay, so in the middle of this chaos, how do doctors even figure out what's going on? Well, they pretty much become detectives. They're looking for three very specific clues that tell them exactly what kind of emergency they're up against.
And here they are, the three big pillars of diagnosis. First, they listen to the patient's symptoms. The chest pain, maybe sweating, shortness of breath. Those are the body's alarm bells ringing. Next, they look at an ECG, which is like the electrical blueprint of the heart, searching for telltale signs of injury. And finally, they run blood tests looking for specific cardiac enzymes, which are chemicals that only leak out when heart muscle cells are damaged or dying.
This table right here is absolutely key to understanding how they pinpoint the problem. See, on one end, you have unstable angina. There's a clot, it's causing symptoms, but no heart muscle has actually died yet, so those enzyme tests come back normal. A step up from that is an NSTEMI. That stands for non-ST elevation myocardial infarction. Here, the blockage is causing some real damage and those enzymes get released into the blood. And then you've got the STEMI, the big one, an ST elevation myocardial infarction. This means there's a complete blockage, it's causing significant damage, and it creates a very specific, very obvious pattern on the ECG called an ST elevation.
The second that STEMI diagnosis is made, the clock starts ticking loudly. Every single minute that goes by, more precious heart muscle is being lost forever. So how does the medical team fight back?
This is the immediate game plan. Right away, the patient is hooked up to a cardiac monitor. An IV line goes in. That's the lifeline for emergency meds. Now, oxygen is only given if their levels are actually low, because we now know too much can sometimes make things worse. And this part is so important. They're given a big dose of aspirin to chew. Yeah, they literally have you chew it. Why? Because it gets absorbed super fast through the tissues in your mouth, straight into the bloodstream, so it can start working on that clot almost instantly.
Okay, so job one is to attack that blood clot. And to do that, doctors have this powerful arsenal of medications. You can think of it as a multi-pronged pharmacological attack designed to stop that clot dead in its tracks and keep it from getting any bigger. The first wave of that attack is the antiplatelets. Now, these drugs don't actually bust up the clot that's already there. Instead, they work on the platelets, those tiny little cells in your blood that clump together to form clots. Antiplatelets basically make them super slippery, kind of like coating them in Teflon, so they can't stick to each other and make the blockage any worse.
Next up, you've got the anticoagulants. So if antiplatelets make the platelets slippery, anticoagulants do something different. They go after the proteins in your blood called clotting factors. They act as clot growth inhibitors, directly getting in the way of the chemical chain reaction that actually builds the thrombus, or the clot.
So here's the typical drug cocktail they'll use. You've got aspirin as that immediate first defense. Then they'll add a more powerful drug called a P2Y12 inhibitor, like clopidogrel, for a real 1-2 punch against the platelets. And on top of that, an anticoagulant like heparin is given, usually through that IV, to stop the clot from expanding while the team preps for the next, most critical step.
But you have to remember, all those medications, they're just buying time. They stabilize the situation, but they don't get rid of the physical blockage.
The final, ultimate mission is to get that artery open and get the blood flowing again. The medical term for this is reperfusion.
And when it's a STEMI, this number is everything. 120 minutes. 2 hours. From the moment that STEMI is identified, the clock is on. The goal is to get that artery open within 120 minutes. This target, it's often called door-to-balloon time, drives every single decision that's made from that point on.
So there are two main ways to achieve reperfusion. Path A, the gold standard, is called PCI. This is a mechanical fix. A cardiologist physically threads a tiny catheter up to the heart, inflates a balloon to open the artery, and usually places a small mesh tube called a stent to keep it open. But if a hospital can't get that procedure done within the 120-minute window, they pivot to Path B, a chemical solution called fibrinolysis. This involves using powerful clot-busting drugs that are designed to literally dissolve the entire blockage.
And why all this urgency? Why the frantic race against the clock? Because it works. As all the medical evidence confirms, getting that blood flowing again, or reperfusion, dramatically improves a person's chances. The entire modern emergency response system is built around this single life-saving principle: time is muscle.
So we've just walked through this incredible, high-stakes medical chain of events, from diagnosis all the way to reperfusion. But you know where that chain really begins? It doesn't start in the ambulance or the emergency room. It starts with the person feeling that chest pain. All of this amazing, life-saving medical science we've just talked about, it's all triggered by one simple, crucial action: making that call for help. Because the most advanced medicine in the world is useless if the clock runs out before the patient ever gets through the door.